Welcome to our daily roundup. We're going to be talking about button battery ingestions and what all surgeons should know. This work started as a task force with the AAP and has really extended out into APSA and other areas to really try to spread the education on what we can do as pediatric surgeons to decrease these injuries and also advocate with industry and the government to make button batteries safer. So Mina Wick and Joanne Berg will be giving the presentation today. Thank you all for coming, and thanks to the program committee for allowing us to present our work.
Good morning, everyone. I hope you all enjoyed last night's presidential banquet and the dinner and dancing. We have some really exciting and important sessions again today with our two final scientific sessions and one more set of breakout sessions. And then please, after the breakouts, do return because all of our award presentations will be happening. I'm pleased to introduce the moderators for the next session on fetal diagnostics and therapeutics. Dr. Tim Janselowitz is an associate professor at Le Bonheur Children's Hospital, the University of Tennessee Health Science Center in Memphis, Tennessee. Dr. Marissa Schwab is a general surgery chief resident at the University of California, San Francisco in San Francisco, California. And Dr. Pamela Choi is an associate professor of surgery and incoming program director of the general surgery residency program at the Naval Medical Center, San Diego. Thank you.
Good morning. Not a bad turnout. Impressed. The first presentation today is physiologic and histologic outcomes of prolonged partial liquid ventilation and pumpless extracorporeal membrane oxygenation supported CDH model LAMs, presented by Alicia Eubanks. Chop.
Good morning. Thank you for the privilege of the podium. We would like to acknowledge with gratitude that this work is supported in part by the APSA Foundation Grossfeld Scholar Grant. Our work in the lab focuses on evaluating novel therapies to shorten and decrease the morbidity of therapy during ECMO support in severe CDH. We're evaluating two therapies, pumpless arteriovenous ECMO and perflubron partial liquid ventilation as treatments for CDH-associated respiratory failure. Perflubron is a perfluorocarbon liquid with low surface tension and high density at atmospheric pressure. It has a surfactant-like effect. PFCs have low van der Waals forces and a high carrying capacity for oxygen and carbon dioxide, enabling liquid breathing. They are also radio-opaque and are used as contrast agents. Partial liquid ventilation is an approach in which perflubron is instilled in the lungs during continuous positive pressure ventilation, and the liquid-filled lungs are ventilated with tidal volumes delivered by a conventional ventilator. PFCs have been studied in a number of disease processes, including prematurity, bronchopulmonary dysplasia, and ARDS, but clinical use is limited currently. The theoretical impact of liquid ventilation in CDH is both mechanical, with liquid distension of the fluid-filled lung tissue to encourage growth, and anti-inflammatory, with potential impacts on pulmonary vascular remodeling. The objective of this study is to evaluate the physiologic and histologic impact of partial liquid ventilation therapy in CDH LAMs supported by pumpless ECMO. After fetal surgical creation of CDH in mid-gestation, LAMs are delivered by exit to ECMO and are subsequently intubated and stabilized on conventional ventilation for a period of 24 hours prior to initiation of liquid ventilation. Of note, due to the severity of the model and inability to stably ventilate these LAMs for prolonged periods, we choose to use ECMO to permit more long-term studies of the effects of perflubron. We have previously presented our work on pumpless ECMO, which consists of a short length of heparin-bonded tubing connected to a low-resistance oxygenator membrane in an arteriovenous configuration, with the advantage that it can be run with minimal to no systemic heparin for a period of up to 21 days. Partial liquid ventilation was initiated with installation of 10 mL per kg of perflubron via the endotracheal tube on day of life 1. Repeated doses of 2 or more mL per kg were administered every 6 hours to maintain a meniscus-filled state. The animals were cared for 24/7 in a NICU-like setting for the course of the run, with TPN for nutritional support. Hemodynamics and lung function were monitored continuously, with pressure-controlled ventilation on rest settings. After 21 days of treatment, necropsy was performed to confirm consistent size of the diaphragm defect and visceral herniation, and lungs were collected for histologic analysis. A total of 10 LAMs were treated, 5 per cohort. Animals maintained flows of up to 100 to 120 mL per kg per minute, consistent with flows seen in pump-driven ECMO. We observed stable systemic blood pressure and circuit flow over 21 days with no requirement for pressor support and no challenges in maintaining target blood gas profiles. We found no evidence of thrombotic or embolic complications on necropsy. Importantly, we observed a 24% reduction in sweep gas required to maintain the target PCO2 in our liquid-treated animals. Liquid ventilation was associated with increased pulmonary compliance, peripheral oxygen saturation, and pH. These images show representative samples of lung tissue from lambs treated with liquid ventilation on the top and conventional ventilation on the bottom. Liquid-treated lambs showed significantly reduced severity of characteristic CDH features, including reductions in pulmonary arteriolar medial wall thickness, alveolar septal wall thickness, and alveolar septal volume density. Partial liquid ventilation in CDH lambs significantly improved pulmonary compliance, oxygenation, and histologic markers of disease, while reducing dependence on ECMO for gas exchange. This therapy may therefore shorten ECMO duration and treat pulmonary hypoplasia and ultimately improve outcomes in CDH. As a next step, we are now addressing the question of whether liquid ventilation could permit early weaning off of ECMO in the CDH lamb model. Early results are promising, with successful weans off of ECMO at day of life 5 to 12 in the liquid ventilation group, and an inability to wean off ECMO to the ventilator in 21 days in a control lamb. The figures shown here compare the ventilator data of a set of CDH lamb twins, one treated with liquid ventilation and one without. While we still need to perform the experiment in several more animals to validate these results, we're excited about the potential clinical significance of these findings. I'd like to thank Dr. Partridge and the team of fantastic lab technicians who made this experiment possible. Thank you for your attention, and I'll take your questions.
George Mihalishka, Ann Arbor. First of all, great presentation, wonderful, innovative work. My question for you is, do you see a role of partial liquid ventilation for premature infants? So you may know that in our artificial placenta setup, we fill the lungs with perfluorocarbon. And do you see a similar role of transitioning from extracorporeal support to liquid ventilation as a bridge to air breathing?
Thank you for your question. That is an interest of our lab. We have some planned experiments, as you describe, using partial liquid ventilation as a bridge to wean off ECMO in premature lambs. Those studies are not yet ongoing, but in the works.
May I ask one more question?
Sure.
So you may be familiar, several decades ago, there were clinical trials of partial liquid ventilation, and the FDA shut those trials down for lack of efficacy and safety issues. Do you have any thoughts about if this is truly efficacious in the lab, what would be your path forward with the FDA given that history?
Given that history, I think indications for a clinical trial would need to be very narrow, a very select group of patients to qualify so that we're not seeing off-target effects that might actually cloud the results in the patients who could actually benefit.
Thank you.
Thank you.
Has there been any change in perfluorocarbon or other options or things you could put in it to make the outcomes even better? Has it changed over the years, do you know?
To my knowledge, the substance is fairly similar to what was used many years ago. Obviously, throughout the years, we have improvements internationally in manufacturing and quality control.
I'll just add a note to further update our response to George's excellent question. We recently did acquire orphan drug status through the FDA for perfluburon for CDH. So although it will be a very limited and carefully applied indication, at this time we do have FDA support to embark on clinical work. So hopefully this is something that we will update the group on soon.
All right, I think we'll move on to our next speaker. Thank you.
Thank you.
Our next speaker is Dr. Brianna Spencer, who will be presenting a pumpless pediatric artificial lung maintains function for 72 hours without systemic anticoagulation using the nitric oxide surface anticoagulation system.
Good morning. Thank you for the opportunity to present our work. I have nothing to disclose. Children with end-stage lung disease are commonly managed with extracorporeal life support as a bridge to lung transplantation. A pumpless pediatric artificial lung, or M-lung, is a simpler alternative to ECLS and allows for ambulation, the potential for care outside of an ICU setting, and improved recovery with physical therapy. Both ECLS and pumpless artificial lungs require systemic anticoagulation, which is associated with hemorrhagic complications. A nitric oxide system with a coated circuit and nitric oxide in the sweep gas has demonstrated anticoagulation properties in our lab. We tested the M-lung with our novel nitric oxide surface anticoagulation system to determine if it can successfully provide local anticoagulation for 72 hours of support in a pediatric size ovine model. We studied 4 healthy pediatric sheep, 14.5 to 19 kilograms. They were anesthetized following our standard anesthesia protocol and underwent left thoracotomy and cannulation. A 100 unit per kilogram bolus of heparin was administered for cannulation and not redosed. Once the lung was attached, 100 parts per million of NO sweep gas was administered. The sheep were recovered from anesthesia and monitored in the ICU setting for 72 hours. Pulmonary artery inflow and left atrial outflow were necessary for the function of our low-pressure pumpless circulation system. 28 French cannulae were used along with Dacron grafts to secure the cannula to the left atrium and the pulmonary artery. The M-lung is a low-resistance hollow fiber lung rated at 2.46 liters per minute, designed in our lab primarily for pediatric patients. All sheep were viable for the 72-hour duration of the study and remained hemodynamically stable throughout without requiring blood transfusions or pressors. Mean cardiac output in sheep was measured at 2.7 liters per minute. Device blood flow across the M-lung average was 836 milliliters per minute during the 3-day study, which represented an average of 32.6% of the cardiac output. The M-lung did provide consistent oxygenation throughout the prep. M-lung inlet oxygen saturation average was 55%, and the average outlet oxygen saturation was 97%, as measured on pre- and post-M-lung blood gases. The pressure drop across the M-lung remained low throughout the prep and averaged 3.5 millimeters of mercury, which was associated with a calculated resistance of an average of 4.3 millimeters of mercury per liter per minute. ACT averaged 170 seconds, which was lower than the therapeutic range typically used in sheep in our lab due to their increased thrombogenicity, which is represented by the gray bar on the graph at 240 to 280 seconds. Met hemoglobin remained low with an average of 2.9%, which is below the level where deleterious effects of nitric oxide can be seen. The average hemoglobin across all sheep remained stable throughout the prep with an average of 9.1, and that remained similar at 72 hours. Platelet levels declined throughout the duration of the study with an average baseline of 590 and final average values at 160. This was expected for our prep. Flow cytometry was also performed to assess platelet and white blood cell activation. There was no significant difference for any parameter at hour 0 versus hour 72, although we note our sample size is small. Circuits and lungs were inspected for clot formation at the termination of prep. Small clots were found at the connection sites but remained absent from the majority of the circuit. Minor clotting was found on the outer portion of the lung fibers, but was not found to be clinically significant in reducing flow or increasing pressure drop. All animals underwent necropsy at the conclusion of the study without significant clot burden noted. Overall, this study demonstrates efficacy and safety of the NOSA system over a 72-hour period in preventing clot formation in this circuit with minimal white blood cell activation and a typical platelet drop. Additionally, the M-lung worked well with low resistance and low pressure drop throughout. This increases the potential for long-term pumpless gas exchange without anticoagulation. In the future, we plan to test our system on an acute respiratory failure 7-day model. I'd like to thank the ECLS lab team and all students and volunteers who helped to make this project possible. Thank you. I'll take any questions.
Kunisaki, Johns Hopkins. Really tremendous work from you and the Herschel group there. Guys should really be commended. These are incredibly labor-intensive experiments, as you know. My main question for you is what is known about sort of the half-life of these the nitric oxide donor sort of system? It's coated, and so presumably you would have to either change the circuit or do something long-term, since I assume that long-term these are supposed to be as a bridge to transplantation. What do we know about that, and are there ways to address that? Thank you.
Sure. Thank you for your question. Right now, our coated circuit lasts for 30 days with releasing properties. And so at that point, we would have to address switching out the circuit after a 30-day time period.
I have a question. You looked at the clot formation in the circuit. Did you look in the animals themselves for any evidence of clot?
Yes, at necropsy at the end of the procedure, we looked through all organs, especially the lung, and didn't notice any clots.
Do you have a control cohort, or how does this compare to the heparin-coated tubing?
Sure. We did have 24-hour studies with a heparin-only group, and they performed similarly.
Any other questions? All right, thanks.
Thanks so much.
The next presentation is transamniotic delivery of surfactant protein B, SPB, mRNA, a potential novel strategy for the perinatal management of congenital SPB deficiencies and surfactant replacement therapy, presented by Kamila Moskowitz-Kova.
Thank you.
Austin.
Good morning, and thank you for the opportunity to present our work. We have no disclosures. Pulmonary surfactant is a complex lipoprotein mixture produced by type 2 cells in the lungs. By lining the epithelium at the air fluid interface, it reduces pulmonary surface tension and therefore allows for adequate gas exchange. Lipids, especially phospholipids, constitute the majority of the surfactant mixture, yet proteins play a central role in surfactant function by stabilizing the mixture and facilitating the lipid absorption to the surface of the alveoli, thus creating an active surface monolayer. Of the 4 protein components of surfactant, SPB, or surfactant protein B, is the most important in such a role. Surfactant simply becomes ineffective in the absence of SPB. Its importance is further reinforced by the fact that mutation in SPB gene can cause a severe neonatal respiratory disease. A prime example of this is congenital SPB deficiency, which is a genetic disease that leads to neonatal respiratory failure despite exogenous surfactant administration, and the only treatment is the lung transplantation. Much more common, respiratory distress syndrome of prematurity is also directly linked to surfactant deficiency, including SPB. Current surfactant replacement therapy does not exactly resemble the human surfactant mixture, and there is still notable mortality and morbidity. mRNA therapies have emerged as a powerful actual or potential alternative for protein replacement in a variety of scenarios, and there are already clinical trials ongoing for treatment of few respiratory diseases, typically as inhalation products. Here at APSA last year, we presented a study using encapsulated luciferase mRNA to examine the pharmacokinetics of transamniotic mRNA delivery, which up to that point was thought to only involve biodistribution via fetal swallowing and aspiration. And we have shown that additionally, hematogenous routing via placenta contributes to the mRNA kinetics, expanding the possible application of TRAINET. In this study, we sought to determine whether exogenous mRNA encoding for human SPB could be incorporated and translated by fetal lungs after simple transamniotic delivery, initially using healthy rat model. And if so, this could become a novel strategy for perinatal surfactant protein replacement or replenishment. A custom-made human SPB mRNA was commercially obtained and encapsulated by a self-assembling lipid and polymer composite into lipopolyplex. The degree of encapsulation of the mRNA was measured by a fluorescence assay. After that, rat fetuses were divided into 2 groups on gestational day 17 or E17, with term being at E21. One group underwent intraamniotic injection of encapsulated human SPB mRNA in older fetuses, while the other group received lipopolyplex only without any mRNA. Then, at daily time points until term, the fetal lungs were analyzed for the presence of the human SPB by ELISA, and levels of phosphatidylcholine, which is a surrogate for overall surfactant production, were measured in the amniotic fluid by fluorimetric assay. Comparisons between the groups were by non-parametric Wilcoxon-Rank-Sum test. The encapsulation rate of human SPB mRNA into lipopolyplex was 96.7%, which was comparable to what we and others have previously reported for other mRNA products. Fetuses that received SPB mRNA showed improved viability compared to controls at two different time points, at E18 and E20. When controlled by mRNA-free injection, human SPB was detected in the lungs at E18, 19, and E21. Lungs levels of human SPB showed statistically significant increase over time in mRNA group, with the highest levels at term. And as you may have noted, ELISA was also positive in a control, which may suggest some degree of human-rat homology for SPB. Amniotic fluid phosphatidylcholine levels trended higher in mRNA group compared to control at term. However, these did not reach the significance. This is perhaps not surprising given the use of a healthy model. To conclude, encapsulated exogenous mRNA encoding for human SPB can be incorporated and translated by a fetal lungs following simple intraamniotic injection in healthy rat model. And transamniotic mRNA delivery could become a novel strategy for perinatal surfactant protein replacement or replenishment. I'm grateful to all my co-authors and to you for your attention. I'm happy to take any questions.
I'm curious how you chose the timing of E17 if you've tried earlier gestational ages.
Yeah, we do a lot of intraamniotic injection in our lab, and we did previously do different time points. However, with a very early time point, given that the gestation of the rat is very short, so E17 is roughly last trimester. So if we try to do it too early, we have a high mortality, given that it's too early in the gestation.
Hi. I was designing Kids Toronto. A very elegant study. Really enjoyed it. I don't want to sound too provocative, but your group has shown beautiful data with regards to the intraamniotic injection of mesenchymal stromal cells. And so I was wondering, and with the benefit on surfactant production. And so I was wondering whether you had a positive control and whether that could fit also that approach with MSC intraamniotic injection could fit also in this kind of clinical scenario.
That's a very interesting question. We actually haven't really looked at surfactant with the stem cells so far. We looked at the surfactant only with the mRNA injection so far, but it's very interesting to try to, for the next projects, to try to combine, not only combine different mRNA that we're injecting, but maybe possibly even in the future combine the cells with the mRNA injections. However, we haven't done that yet.
I was referring to of course, the papers on the CDH model and the promotion of surfactant production.
In CDH model, yeah.
Great work, thanks.
Thank you.
I have one more question. Have you looked at serial amnio infusions and seeing if that increases your phosphatidylcholine levels at term?
Serial intraamniotic injections? Not yet, but definitely that is also something that we could consider. Also, given the fact that we maybe by that approach could increase the amount of mRNA that we can inject. We are in this sort of scenario, we are limited by really short gestation. So this injection basically involves laparotomy. So we would have to reopen laparotomy, which could cause additional negative effects on the mom. But if we proceed to larger models with the longer gestational period, like the lambs, we would definitely, and maybe we wouldn't have to do laparotomy and could just inject with the ultrasound. That would be an option as well.
Thank you very much.
Thank you.
Our next speaker is Dr. Lawrence Willis, and he will be presenting severity misclassification in prenatally diagnosed congenital diaphragmatic hernia. How often are we wrong?
All right, good morning. Thank you for allowing me to talk. I have nothing to disclose. Because of the broad spectrum of severity that characterizes CDH, early and accurate risk stratification is essential for prenatal and postnatal decision-making. It includes delivery planning, termination, and fetal intervention, as well as repair timing and the use of ECLS. So we then asked, when we make a prenatal risk classification, how often are we wrong? And are there any factors that are associated with risk inaccuracy? So then we hypothesized that one, CDH severity misclassification is common and ultrasound imaging is more frequently inaccurate than MRI, and that there are multiple variables that contribute to risk prediction inaccuracy. So we used the CDH study group registry and included only left CDH patients with a prenatal diagnosis and excluded those who had fetal intervention or severe anomaly. Our primary composite outcome was ECLS use or death, and for prenatal predictors, we used the first OE-LHR, OE-TLV, and PPLV. We used established severity thresholds for the 3 imaging predictors. The most severe patients had an OE-LHR or TLV of less than 25% or a PPLV of less than 15%. For comparison with postnatal risk prediction, we used a previously validated model that predicts the risk of ECLS or death using postnatal variables. Mild postnatal risk was defined as a probability of ECLS or death of less than 20%, moderate 20 to 80%, and severe greater than 80%. First, we compared patient prenatal and postnatal severity and estimated the frequency of risk misclassification in left CDH. Then we measured the influence of 4 variables on prediction accuracy: center CDH volume, gestational age at time of study, the year of birth, and presence of a hernia sac. Of 3,189 patients in the registry, 76.2% were pre-diagnosed. Of these, 2,091 had a left CDH, and of these, 31.3% had an OE-LHR, 16.5% had an OE-TLV, and 13.1% had a PPLV. OE-LHR had an AUC of 0.74 for prediction of ECLS or death. The scatter plot here is a visual representation of that risk prediction accuracy and shows mild, moderate, and severe OE-LHR plotted against postnatal probability of ECLS or death. The dotted lines show the thresholds for mild and severe postnatal risk. 3.2% of prenatally mild patients had a postnatally severe phenotype, while 10.6% of prenatally severe patients had a mild postnatal phenotype. OE-TLV had an AUC of 0.75 for prediction of ECLS or death. Just 1.7% of prenatally mild patients had a postnatally severe phenotype, while 7.9% of prenatally severe patients had a mild postnatal phenotype. PPLV had an AUC of 0.75 for prediction of ECLS or death. Just 1 prenatally mild patient had a postnatally severe phenotype, and 1 prenatally severe patient had a mild postnatal phenotype. Here, we show the effect of center volume. As shown in this table, with volume analyzed as a dichotomous variable, there were no major differences in the AUC for prediction of ECLS or death between high and low volume centers amongst any of the imaging predictors. Center volume was then analyzed as a continuous variable using contour plots. The y-axis shows increasing center volume, and the x-axis shows increasing OE-LHR and OE-TLV. The contour lines represent increasing probability of ECLS or death as the color goes from blue to red. For LHR, the contour lines diverge as center volume decreases, suggesting decreasing accuracy for lower volume. In contrast, for TLV, the contour lines remain equidistant with increasing center volume, suggesting no effect of center volume on risk prediction with MRI. These contour plots show increasing gestational age on the y-axis. OE-LHR is somewhat less accurate for risk prediction at lower gestational ages, as demonstrated by the diverging contour lines. Gestational age has almost no effect on the accuracy of OE-TLV, as the contour lines are nearly vertical. In contrast, PPLV is markedly inaccurate at low gestational ages. These annual fit plots show OE-LHR on the x-axis and probability of ECLS or death on the y-axis. As time goes on, the slope increases, which means a greater change in probability with a smaller change in OE-LHR, suggesting an increasing accuracy of OE-LHR and risk prediction over time. This slice plot clearly shows the dramatic change in slope over time with the overlapping curves. In contrast, there is no change in slope over time for OE-TLV, suggesting no change in accuracy with the MRI-based variable year over year. And finally, the presence of hernia sac was associated with a moderately worse AUC for OE-LHR, but not for OE-TLV, suggesting the presence of a hernia sac affects ultrasound accuracy, but not MRI. So we did have some limitations to this study. So there is a small number of MRI patients, especially for PPLV, which may be affecting the data. The data right now is unclear for right CDH. And there may be other accounted variables that may be confounding. But in conclusion, 1 in 10 left CDH patients classified as severe by OE-LHR will have the opposite clinical phenotype. Prenatal ultrasound is more likely than MRI to misclassify CDH severity, but this may be improving over time. A patient with a mild prenatal classification is unlikely to be severe postnatally. And center CDH volume affects ultrasound predictive accuracy more than MRI. Earlier year of birth, presence of a hernia sac are associated with reduced accuracy of OE-LHR. Moving forward, expansion of the use of MRI may improve risk prediction in CDH as does experience with ultrasound. Standardization of reporting and consensus on technique for MRI, as with LHR, may lead to improvements in prenatal risk prediction. And these data can inform prenatal counseling and delivery planning. Thank you. I'm happy to take any questions.
Kunisaki, Hopkins, really great study. About 20 years ago, I sort of had the conclusion that we're not very good at predicting CDH prenatally, and your talk certainly brings back those memories that we're still maybe not very good at that. Nevertheless, I think it's really important work that you highlight because of the fact that obviously it probably explains why things like exit to ECMO for CDH maybe didn't work very well, but also has broader implications obviously in the era of FETO and whether we should be applying FETO and how liberally we should be investing in this technology. My first question, or my major question is what do you think, how should we move the field forward in terms of using MRI? Your studies, your data suggests that we should be using it more. Fetal MRI has been around for over 20 years now for CDH. Is that something that we should be really focusing on? Because I suspect that the centers that are higher volume, that have greater experience with this, are the ones that are contributing the MRI data to your study here.
That's an excellent question. So we did a previous study to kind of create a CDH risk profile that uses a combination of both prenatal and postnatal predictors to help come up with a good risk prediction accuracy. And so for prenatal, we decided to use both OE-LHR for ultrasound and MRI. So a combination of both factors will help in increasing accuracy. So for centers that may not have access to MRI, they can still use ultrasound. And we have seen that over time, that ultrasound is getting better. So just more standardization of the use will help in increasing accuracy.
Great. My second question just involves the co-founder issue. Did you look at liver herniation or degree of liver herniation in this model? Does that contribute at all to, you think, the findings and why we may be getting this wrong still?
So we did look at liver herniation. So it does increase the severity, but overall, the same prenatal risk prediction is still the same, even regardless of the presence of a hernia sac, the presence of liver in the imaging.
Thank you.
Vic Haskett, the UT Houston, UT Southwestern. Great work. One question that I had is, I like that you looked at center CDH volume, but what about center imaging modality volume? Is there any difference in centers that do a lot of MRI or have a ton of experience with ultrasound or prenatal ultrasound, not just for CDH patients?
That is an excellent question. So for the sake of time, I did not include it in this talk, but I do have this slide that shows exactly the question that you're asking. So these contour plots show that for ultrasound, that you can see as the, for smaller amount of ultrasounds, the lines display out, so showing that there's a decreasing accuracy with lower ultrasound. However, with MRI, we see the lines are still equidistant, so there is no change in regards to the amount of MRI in regards to the accuracy.
In the interest of time, we're going to move on to the next presentation. Thank you.
Our next presentation is functional and molecular sexual dimorphism in congenital diaphragmatic hernia, presented by Dr. Olotoye.
Thank you for the opportunity to present. I have nothing to disclose. Congenital diaphragmatic hernia is a complex disorder associated with lung hypoplasia and pulmonary hypertension. This pulmonary hypertension is thought to be due to, in part, increasing fibrosis, inflammation, and collagen deposition in the extracellular matrix of the distal lung. At our institution, we have a clinical impression that there are sex-based differences in clinical outcomes in CDH. And so to further study that, we performed a single-center retrospective cohort study at our institution that showed a trend toward increasing mortality in males. However, when we stratified or controlled for lung volume, we didn't see, or the mortality was no longer significant. However, ECMO use still had an increased odds in males as compared to females. And this led us to ask, are there sex-based differences in CDH at a molecular level that correlate with what we've seen clinically? Our objective was to understand the molecular heterogeneity in the distal lung in CDH with the goal of identifying gene targets and pathways involved in CDH pathophysiology. And to understand this, we performed spatial transcriptomics on the actual lung tissue of patients with CDH. We took patients with CDH. At autopsy, we always collect lung tissue specimens. And so we use those paraffin-embedded specimens, selected regions of interest at the distal lung, of the distal lung parenchyma, and we performed spatial transcriptomics on that. As a control, we used lung resection tissue from patients with congenital lung malformations, and we took the healthy aspect of those tissues and selected regions of interest and did spatial transcriptomics on that. We did whole transcriptome atlas analysis and gene set variation analysis to determine differentially expressed genes and enriched pathways. And the significance was determined by dual thresholding with a p-value of less than 0.05 and an absolute log2 fold change of greater than 0.05. And so these volcano results show our results here. On the left, we see CDH in males with CDH compared to control, there's about 232 differentially expressed genes. And on the right, volcano plot shows about 202 differentially expressed genes in female CDH as compared to the controls. If you focus on the data set or the data points in orange, those are the differentially expressed genes that met our dual thresholding. And superior, we see the data points in green, which show this false discovery rate of less than 0.05, which shows even more differentially expressed genes that are more specifically differentially expressed and stood out from the rest. This Venn diagram here shows the overlap between male and female up and down regulated genes that were differentially expressed. And you'll see that there's very little overlap, showing that there's this sexual dimorphism in the genetics of the distal lung of males and females with congenital diaphragmatic hernia. And now I want to focus on some of the differentially expressed genes that we found that we believe are associated with increased inflammation and fibrosis in the distal lung in CDH patients. We saw that in males, COL1A1 and CD163 were upregulated in CDH compared to their controls. Interestingly, COL1A1 contributes to fibrosis and pulmonary hypertension, and CD163 is a macrophage marker, signaling that there's this pro-inflammatory, pro-fibrotic state in the males with CDH. In females, we saw that CCN1 and SGK1 were downregulated in females with CDH as compared to their controls. CCN1 modulates inflammation and repair and suppresses hypoxia-induced smooth muscle contraction. And SGK1 is a stress-responsive kinase that's increased in pulmonary hypertension, and loss of SGK1 has been shown to decrease hypoxia-induced pulmonary hypertension in mice. And so you can imagine if you have these two genes decrease in females, that may potentially be creating a protective effect in these females that can be allowing them to have improved clinical outcomes. When we look at enriched pathways, we see upregulation of pathways in male distal lung associated with increased inflammation and downregulation of pathways in female distal lung that are associated with increased inflammation. And we also see downregulation or negative enrichment of pathways in females that are associated with endothelial dysfunction. And so, in summary, we see that the transcriptomes of CDH lung specimens support the role of fibrosis and inflammation in CDH patients. And there are sex-specific gene signatures in the distal lung of patients with CDH that may account for what we're seeing clinically. A further study of these sex-based differences in CDH may explain the differences in clinical outcomes we're seeing, allow further understanding of the pathophysiology of CDH, and will hopefully lead to precision-tailored therapies to treat these patients with CDH. Thank you, and I'll be happy to answer any questions.
Really outstanding, innovative work and beautifully presented. George Mihalishka from Ann Arbor. This makes me think of a spin-off. And could you do one more study?
Of course.
Okay. So it is well known that female infants that are extremely premature, their survival far exceeds male infants. And I wonder, it's likely due to gas exchange and lung development, pulmonary hypertension, et cetera. I think this would be really interesting study to replicate on extremely premature female and male infants. You may have similar findings. Just spectacular work. Congratulations.
Thank you, sir.
I can only echo what Dr. Michalska just said. It's really elegant and very innovative. My question for you is about the age of the specimen, of the patients the specimens were taken from. Were these fetuses, or were these specimens from babies that were born and post-mortem?
Thank you for this question. So for our CDH patients, these are specimens for babies who were born and post-mortem in their autopsy. And the age of the specimens, the oldest baby died at 102 days.
Because then I know that you guys have a lot of money in Houston, so I would add another study to do to the one just proposed, and I would look into the fetuses and what we've shown in the animal model, but also in human fetal lung specimens from post-mortem, is that in fact there is inflammation already and antenatally. And so it would be great to see whether there's differences, especially with the spatial transcriptomics analysis. Very elegant, great work.
Thank you.
Yeah, and I'd worry about the age of the patients that didn't survive. You know, what was the duration of ventilation and how would you control for that? Because if you've been on the vent forever, maybe you're seeing the effects of iatrogenic lung damage.
That's a great point. You know, that's one thing, that's one limitation of the study, definitely, and something that's hard to control for in a study like this.
Thank you very much. I think we're going to move on. I'm sorry. Our next speaker is Dr. Juan Biancotti, who is presenting functional activity of spinal cord organoids generated from human amniotic fluid stem cells, a novel approach for disease modeling in autologous therapy in myelomeningocele.
Good morning, and thank you for the opportunity to present our work. Every day, 4 children are born in the United States with a myelomeningocele, which is a severe form of spina bifida. The diagnosis is associated with hydrocephalus, leg weakness, paralysis, and bladder and bowel dysfunction. There is a need, the prenatal surgical repair has been shown to improve the clinical outcome, but there is still neurological complications that remain in many children. There is a need for novel treatments to address the regeneration of the damaged spinal cord in myelomeningocele. The purpose of our study was to generate functional human dorsal spinal cord organoids from amniotic fluid derived induced pluripotent stem cells to use a novel strategy for disease modeling and for therapy as well. Under institutional approved protocols, we collected amniotic fluid from healthy control and MMC fetuses. We collected the cells and reprogrammed them to induce pluripotent stem cells by transduction with non-integrating Sendai virus, and then differentiated them into spinal cord organoids to perform further functional and characterization, phenotypic and functional characterization using a multi-electrode array. On day 24, organoids, the gene expression indicates the presence of cells from dorsal and ventral spinal cord domains in both, in the myelomeningocele and control spinal cord organoids. When we analyze the gene expression of the Hox gene, the family family of transcription factors, we found cells spanning the whole spinal cord from cervical throughout lumbar domains, with a reduction in the cell number from rostral to caudal regions. We did immunohistochemical analysis, characterization, and later time points. And we can see at day 60 that there is an expression of TURCH1 and MAP2 early neurons, as also GFIP positive astrocytes, and we were able to see few scattered NUM positive late neurons. At day 101 and 130, we could see a more extensive expression of GFIP with a slightly increase in positive NUN late neurons. What is interesting from here is the presence of PCNA positive cells, which indicates continuous cell renewal. To verify if these neurons that we identify by immunohistochemistry are actually functional, we perform activity scan trying to record spontaneous electric activity using a microelectrode array. On the right, we can see the device, the recording unit, and one organoid sitting on the electrode array. And on the left, we see the shape of the organoid sitting on the matrix, on the array, which is registered by the spontaneous electric firing of each of the neurons that shows activity. And we can see different metrics for these recordings, such as firing rate and amplitude of the signal. On the top left, the raster plot shows on the y-axis all the electrodes of the array, and on the x-axis, the time recorded. And that allows us to see that several neurons fire at the same time. That indicates that there is connectivity, synaptic connectivity between the neurons, and there is formation of active networks. On the right, we have different parameters that can be measured from this recording, the metrics. We were also able to track the axon for different neurons. On the left, we have an example for one single neuron in which we follow two different axons, and we were able to measure the conductance velocity and length of the axon for each of them. On the right, there is the same parameters are seen in different neurons, in different axons for different neurons, all recorded simultaneously. Importantly, the parameters the metrics we recorded for our spinal cord organoids are similar to other organoids that have been also recorded, like hippocampal cortical or even whole brain organoids. So as a conclusion, for the first time, we describe a method to derive human 3D dorsal spinal cord organoids from MMC fetuses. These organoids display spontaneous electric activity and formation of active neural networks. This is a strategy, patient-specific in vitro platform to study MMC, spinal cord development, and disease pathogenesis. And these spinal cord organoids may represent an autologous source for neural progenitor transplantation to facilitate the spinal cord regeneration at the time of MMC repair. Thank you for your attention. I'll be happy to answer any questions.
I think we only have time for one question. I'm curious, now that you've shown that there was spontaneous electrical activity in the organoids, have you thought of ways to augment that to clinically significant levels?
Well, yes, somehow, because showing that the neurons are active makes them a better tool to help them be incorporated into the spinal cord when there is this damage, and that they are going in the right direction in terms of functionality. So yes, it's an important factor to consider, definitely.
Thank you.
Our next presenter is Ernesto Rojas, who's presenting transcriptomics and mouse modeling of sacrococcygeal teratomas from UCSF.
Thank you very much. My name is Ernesto Rojas, and I'm an MD PhD candidate in the labs of Diana Laird and Tippy McKenzie. I have nothing to disclose, and I study sacrococcygeal teratomas. What you see pictured here is an MRI of an SCT, and as you all know, some of these SCTs can require a fetal resection when they're fast growing. However, most resections occur postnatally. Resections are usually curative. However, there is a risk of recurrence, and it is difficult to know which patients will have recurrences. And the root of both of these issues, knowing which patients will have the most aggressive tumors and knowing which will have recurrences, both go to the root of the issue, which is that we don't know what the cell of origin is for SCTs. The hypothesized cell of origin so far is the primordial germ cell or the gamete precursor, which has undergone a transformation to a pluripotent cell. And pictured here is actually a fetal SCT from UCSF, where you can see the large tumor, a IV in the saphenous vein, and then a catheter pointing towards the anus. And these fast-growing aggressive tumors are the ones that are most interesting for our projects. We have three major aims, the first of which is trying to model this process in mice using a fetal injection of pluripotent cells into the mouse sacrum. And then the second and third aims are using our clinical samples and then taking advantage of innovative next generation sequencing technologies like single cell transcriptomics and spatial transcriptomics. So the hypothesis for the first aim is that by injecting pluripotent cells into the sacrum of mice, we can recapitulate the SCT formation. And the hypothesis for the two second aims are that we will find tumor initiating cells in the most aggressive SCTs and not in the small cystic ones. So we'll begin with aim 1. And to do the mouse injection model, we exteriorize the mice at mid-gestation, and I can inject cells into the sacrum. And as you can see here, this is dye being injected into the mouse fetuses. From there, we can take the fetuses and image them. The cells that we inject are all marked with green fluorescent protein, which you can see here in green. And then I've marked here in red PCAM, which is an endothelial marker, and OCT4, which is a pluripotency marker, which you can see here all in the sacrum of these injected fetuses. For aims 2 and 3, we take advantage of really innovative technologies called single-cell transcriptomics, where we dissociate the tissue, and what you'll see is actually cells being introduced into these droplets. Once they're in those droplets, we can sequence the entire transcriptome of each of these cells that are barcoded, and then look at what genes are expressed in which cells. We may then make a graph called a UMAP, where each one of these dots represents a cell for which we have the entire transcriptome information for the genes that are expressed. I've pseudo-colored here 4 samples that we currently have, 3 of which are SCTs, and 1 is a neck teratoma. From there, I look for markers of pluripotency, and here we see OCT4, and what I want you to notice is that the cells that are in black express OCT4, and you can see that there's a small population of cells that are expressing the pluripotency gene, being consistent with my hypothesis. Because of innovative technologies that we heard about from previous speakers, we can take advantage of bank samples, and here we have a fetal surgical specimen, and I hope in brown you can see that this is immunohistochemistry analysis of OCT4 staining, and we're actually currently undergoing the sequencing. I'm just getting the results actually yesterday, so we'll be looking at these cells and then looking at what genes are expressed within these populations. So in conclusion, in our mouse injection model, we can introduce cells into the sacrum of mice, and this supports the feasibility of the mouse SCT model. Fresh and bank samples of SCTs can actually show us cells that are expressing OCT4, which point to the possible tumor progenitor that we will further characterize, and spatial transcriptomics will serve as a really powerful tool to locate and characterize the tumor progenitors in the microenvironment. I, of course, would like to thank my 2 PIs, Drs. Tippy McKenzie and Diana Laird, and none of this work would be possible without the generous collaboration of our fetal surgeons, Drs. Lan Vu at UCSF and Dr. Chris Darian, who's in the audience at Colorado Children's Hospital. And because this is a rare tumor, we are always looking for collaborations for more SCTs, either fresh or banked. Please reach out to either myself or Dr. McKenzie, and I'm happy to take any questions at this time.
So do you have any ideas of what your epigenetic targets might be going forward?
Yeah, so what's really interesting is that the primordial germ cells can actually undergo a spontaneous transformation into a pluripotent cell. And one of the reasons is that the primordial germ cells are in a state of close to pluripotency. So they actually also express OCT4. And so the idea is that through exogenous signaling, they can undergo enough transformation to turn on the rest of the pluripotency network. And so we'll see what genes those are.
Thank you.
Great. Thank you very much.
Thanks.
Our next speaker is Dr. John Riley, who will be presenting fetal gene editing evades maternal T-cell immunity to Cas9 endonuclease.
Good morning. In adults, gene editing is significantly impaired by pre-existing immunity to several components of the technology. Now, this was first discovered with respect to humoral immunity to adeno-associated viral vectors, but more recently, and perhaps more importantly, it's also been recognized with respect to T-cell immunity to Cas9 endonuclease, which is the enzyme that cleaves DNA in the CRISPR-Cas system. For those of us who are interested in treating genetic disease by means of a fetal gene editing strategy, this provokes the following question. If T-cell immunity to Cas9 endonuclease is present in the mother, does that bear upon our ability to safely and effectively gene edit the fetus? To study this problem, we use a straightforward fluorescent gene editing reporter model, where in successful delivery of an adeno-associated virus subtype 9 with a strep pyogenes Cas9 endonuclease results in a change from constitutive expression of membrane-bound tomato to membrane-bound GFP in target tissues. In order to induce pre-existing immunity to Cas9 in female mice, we inject them twice intramuscularly with purified Cas9 protein with a saponin-based adjuvant 1 week apart. And after 29 days, we confirm the presence of a T-cell immunity by means of a delayed type hypersensitivity reaction, which you all know about because it's very similar to a PPD for tuberculosis. We mate these females to our fluorescent reporter murine strain and then perform our gene editing on gestational day 16 with the vector I described to you. After fostering these mice at birth, we look at 2 and 12 weeks post-injection for evidence of persistent gene editing in the liver, as well as various metrics of a T-cell immune response to Cas9. So first, with respect to that delayed type hypersensitivity reaction I showed you, I want you to look at the middle mouse, which has been previously sensitized to SB-Cas9 protein and then challenged with an intradermal injection of that protein into the right ear. And I hope you can appreciate that right ear, and only that right ear, is swollen and erythematous. When we look at that ear under the microscope, we see in this bottom middle panel here, not only edema, but abundant small blue lymphocytes, confirming the presence of a T-cell immune response to the injected protein. This can also be quantified using microcalipers measuring the ear thickness, and we see that this is a consistent effect in all of the female mice in this subgroup. Now, when we proceed to perform our gene editing strategy on the offspring or fetuses carried by these dams, the result is very simple. Whether in the offspring of SP-Cas9 sensitized or unsensitized dams, we see numerous bright green cells populating the liver. When we further quantify this using flow cytometry, we see that the magnitude of editing is comparable between the groups, both in the short term as well as in the long term. So in other words, there's not a delayed loss of previously edited cells that is characteristic of the adult immune response. We further looked at the prevalence of T cells in the liver, first looking at all T cells and found that they were comparable between the groups, but more importantly, using cell surface markers, we can differentiate and look for maternal-derived T cells, and we find no evidence of persistent maternal T cells in the target organs. When we look for the specific subtype of T cells that's responsible for this effect, that being cytotoxic T cells and activated cytotoxic T cells, we see that they are few and comparable between the groups. And finally, when we look for evidence of hepatocellular injury by means of serum transaminases, we see no evidence of that in both cases. It's low in both groups. And then when we look at these organs underneath the microscope, we see first normal liver architecture with no evidence of hepatocellular injury, and finally looking for tissue-resident or tissue-infiltrating cytotoxic T cells by immunohistochemistry. Again, we see no evidence of that. What this data shows us is that with respect to maternal T cell immunity to Cas9 endonuclease, the transmission to the fetus is inefficient. And a fetal gene editing strategy leverages that inefficiency to circumvent an important immune barrier present in adults. Thank you very much for listening and for those who helped me with this work.
Did you do any integration analysis, especially in the gonadal tissue?
We did not for this work, no. We've done it in other models in the lab, including in a recently published paper in the mini pig model, but we did not do it for these murine studies.
Thank you.
Thank you.
Our last presentation is fetoscopic myelomeningocele repair is associated with less fetal bradycardia compared to open repair, presented by Stephen Papastefan.
All right, thank you. Fetal bradycardia is a known terminal indicator of fetal stress and develops in response to fetal hypoxia, acidosis, and hypothermia. Often, by the time a fetus has developed severe fetal bradycardia, the fetus is extremely sick and fetal demise can be imminent. However, if we're able to detect early signs of fetal distress, we can initiate maneuvers to interrupt this cycle, such as maternal blood pressure support, fetal repositioning, rewarming if hypothermia is suspected, or in more severe cases, administer epinephrine or atropine. The success of these maneuvers is largely based on detecting the problem early enough before things get really bad. Open and fetoscopic spina bifida repair each have advantages and disadvantages with respect to post-surgical outcomes, but the effect on fetal physiology is incompletely understood. Fetoscopic repair takes significantly longer, typically 5 to 6 hours compared to open, which takes around 2 hours. And with this longer duration is the associated prolonged exposure to inhaled anesthetics. Additionally, fetoscopic procedures introduce the variable of intrauterine insufflation pressure, which if not carefully considered, can exceed typical umbilical venous pressures and potentially impact fetal blood flow. Therefore, we hypothesized that the incidence of fetal bradycardia would be higher in open compared to fetoscopic repair. We performed a retrospective cohort study of open and fetoscopic repairs at our institution between 2017 and 2022. We performed 25 open spina bifida repairs, and after November 2020, 26 fetoscopic repairs. Intraoperatively, a fetal echocardiographer monitors the fetuses throughout the case, and fetal heart rate was recorded every 15 minutes, and mothers were continuously monitored, and data was extracted every 30 minutes. Our outcomes were the incidence of fetal bradycardia, which we defined based on standard American College of Obstetrics and Gynecology definition of less than 110 beats per minute, and marked decelerations, which was defined as greater than 25 beats per minute. With the first category of fetal bradycardia, we aim to capture the early bradycardia when resuscitative maneuvers can still be considered. And with decelerations, we aim to capture the significant fluctuations given the variable baseline heart rates present between fetuses. So we first asked the question, what is the incidence of fetal bradycardia in open versus fetoscopic repair? Contrary to our hypothesis, we were surprised to find that fetal bradycardia occurred significantly more commonly in open compared to fetoscopic repairs at 32% of patients in open compared to 3.8% in fetoscopic. Additionally, we found that marked decelerations were more common at 20% compared to 3.8%, but this did not quite reach significance. There was one fetus in each group that required an emergent delivery, but no differences between the two groups. We then asked the question, when do these bradycardic events occur during the operation? We separated our operations into various intraoperative windows, which is displayed on the x-axis, progressing from preoperative measurement to skin incision, hysterotomy, the fetal cocktail, repair, and subsequent closure. We found that 46% of fetal bradycardia events occur during the fetal spinal repair, with the most common window being during the first third of repair. Most importantly, all events occurred during the hysterotomy window in the case of open surgery when the fetus is physically exposed to the environment. Finally, we asked the question, are the differences seen between fetal heart rates a result of maternal hemodynamics? We plotted maternal blood pressures along our operative timeline, and it's clear there were no major differences between groups. On a subsequent analysis that we conducted, not depicted here, episodes of mean arterial blood pressure less than 65 did not correlate with fetal bradycardia. Second, we looked at differences in phenylephrine utilization, plotted as the red and blue lines on the graph. We found that fetoscopic repair actually had slightly higher overall phenylephrine rates compared to open. We looked at many other maternal variables in addition to what is displayed here, but did not find differences that would account for the differences in fetal bradycardia seen. In conclusion, we found that fetal bradycardia is more common in open compared to fetoscopic repair. And additionally, we conclude that this difference is unlikely related to cumulative anesthetic exposure or maternal hemodynamic differences. Instead, fetal bradycardia occurred exclusively during the fetal bradycardia window. We hypothesized that fetal hypothermia could play a role, but are unable to assess this due to current limitations of fetal monitoring. Thank you, and I'm happy to take any questions.
Good morning, Cogent Sound from Houston, Texas. Great job really looking at this problem. Your experience actually is the opposite of our own. In our open series, we had less than 10% bradycardia, and our fetoscopic group was almost 50%. And so we should probably talk offline and see what you guys are doing better than we are. My question is, when you looked at your open cases, did you look at some of the general placental anatomy? In our experience, the anterior placentas actually did better than the posteriors. And that's the biggest cohort in our group.
Yeah, thank you. I met one of your colleagues actually at SMFM, so I would be interested to talk a little bit more about that. You know, one difference that we had kind of been talking about was the insufflation pressure potentially used in the operation, and I'm not sure what you all use, but we try to keep it extremely low, just really to the point that you can do the operation safely, but trying to keep it as low as possible. We did not look at placenta location, but it's definitely something to look into, and maybe explain why our rate is actually higher than yours in open.
Thank you.
Thank you.
I have a question. I have a question. I'm from Cambodia. I want to ask you, perform a photoscopy myelomeningocele can avoid neurological.
Why don't I find you actually after this, because
Perfect.
I know we're out of time, and we'll discuss. Thanks.
Thank you. Thank you to all the presenters and to everybody for a lively discussion.